Postoperative care, Chapter 19. The patient's recovery is first handled in the post-anesthesia care unit, or PACU, abbreviated PACU. General anesthesia is administered to patients to induce a state of unconsciousness, produce memory loss, and provide analgesic support during a surgical procedure. Patients who undergo general anesthesia may lose the ability to spontaneously breathe or have an irregular breathing pattern, which requires some form of ventilatory and oxygenation support. Anesthesia and analgesia medications may also alter other systems and affect level of consciousness, mobility, blood pressure, and heart rate, to name a few. Nursing care includes management of the respiratory, cardiovascular, and neurologic problems, as well as pain or discomfort. In addition, temperature, gastrointestinal, and urinary problems may be addressed. The surgical wound is also a primary area of focus. The surgical patient will remain unconscious until the anesthetic agents are stopped. Following anesthesia, the surgical patient requires vigilant monitoring to support respiratory and cardiovascular function until the return of spontaneous reflexes and hemodynamic stability. Care of the patient following surgery begins as the patient enters the PACU. The close proximity of PACU, the post-anesthesia care unit, to the OR minimizes transportation time and provides the patient and PACU staff with immediate access to anesthesia and OR staff while the patient is recovering from anesthesia. The primary goal of nursing care in the PACU is to monitor the patient for complications of anesthesia and/or the surgical procedure. The patient may have received general anesthesia and be completely unconscious, or have received regional anesthesia and lost sensation to part of his or her body. Surgical procedures may require varying monitoring tools. An example would be a PA catheter, or various tubes or drains that require frequent monitoring. 3 phases of post-anesthesia care are phase 1, phase 2, and extended observation, which provide different levels of care depending on the patient's needs. Patients move through the levels of care depending on their condition and the type of anesthesia that they received. Rapid PACU progression, or RRP. If a patient is doing really well, the patient may go rapidly through phase 1 to phase 2 and into an inpatient unit. Fast tracking is another accelerated system of care which involves admitting ambulatory surgery patients directly to phase 2 care. These types of programs are used to facilitate patient recovery and are specific to each surgical procedure. Goals of the fast tracking or rapid progression include cutting costs and increasing patient satisfaction, decrease overall recovery time and length of hospital stays, and decrease morbidity. The patient's safety is the primary factor determining where and at what level we provide postoperative care. The initial recovery period is phase 1. On page 329 in table 19.2 is a table that shows an example of handoff procedure. Please review this table as you will be required to answer a few questions on this. The handoff report is a standardized and interactive report from the anesthesia care provider, or ACP, to the post-anesthesia care nurse. The ACP should stay in the PACU until you or the nurse accepts responsibility for the care of the patient. Basic life-sustaining needs are of the highest priority. Patient is most prone to complications at this time and requires constant vigilance. The patient assessment may include management of an artificial airway, pulse oximetry to assess oxygenation, transcutaneous carbon dioxide, and end-tidal carbon dioxide, or capnography, which is used to monitor and detect respiratory depression. Continuous ECG monitoring for changes in the heart rate that may indicate pain, anxiety, bleeding, hypovolemia, and abnormal electrolytes. Frequent blood pressure monitoring may have invasive arterial monitoring that provides continuous blood pressure readings. These are used for complications of hypo and hypertension. Frequent assessment of circulation, including body temperature, capillary refill, skin color, and moisture is important. Frequent assessment of the neurologic system, such as level of consciousness, orientation, sensory and motor status, and your patient's pupils. Frequent assessment of intake and output is necessary, and fluid balance. Management of IV fluids and medications. This may include some reversal agents for neuromuscular blocking agents given in the OR. Management of catheters and drains. The goal is to prepare the patient for phase 2 or an inpatient unit. During phase 1, a complete physical assessment is performed with emphasis on the surgical area. Thinking about the type of equipment required helps to consider the intense monitoring and frequent care that the patient in phase 1 will require. To manage the patient that has received anesthesia, various equipment is required. If the patient is ventilated, a ventilator will be present with suction set up for airway management. Various artificial airways are also required in the PACU if a patient loses spontaneous respirations, thus requiring mechanical ventilation. Various oxygen delivery systems, such as nasal cannula, face mask, are required that may be specific to the type of surgery, such as facial surgery, or to keep oxygen levels greater than 92%. Various sizes of blood pressure cuffs are also required, with equipment for invasive blood pressure monitoring, such as arterial lines. IV supplies and IV fluids may be necessary to replace fluid loss in the OR. Stock medications, antibiotics, reversal agents, analgesics, medications to control blood pressure and heart rates, and anxiolytics will all need to be present in the PACU. Stock items may also include Foley insertion kits, dressing supplies, and NG tubes such as Salem sump supplies. The PACU handoff report, again, 329 table 19.2. Handoff reports, again, should be standardized and interactive, allowing for questions and clarification of information. The anesthesia care provider should remain in the PACU again until the responsibility of the patient is accepted by the PACU nurse. An example of a handoff report is as follows. This is Miss Anna Jones, 56-year-old female, had a screening colonoscopy with Dr. Smith. She did fine and is awake and alert. Patient is stable and has a 22 gauge IV in the right antecubital, infusing normal saline at 100 mils per hour and is on oxygen via nasal cannula at 2 liters per minute. The patient was given propofol in surgery. She had no difficulties and is breathing on her own without problems. The patient has diabetes and has hearing aids in a blue container under the cart. The patient is allergic to sulfa drugs. The patient had several polyps removed that will be sent to the lab. Otherwise, the colon looks normal. Vital signs remained stable throughout the procedure. This table also contains report information that you would want to get both intraoperatively and during the course and for management. So we would want to be sure to know the anesthetic medications used and pass that on to the person taking over. Blood loss estimated in milliliters, what we replace that blood loss with, what types of fluids. We'd want to also tell them their urine output to make sure it is adequate. And we'd also want to tell them of any kind of unexpected events that happen during the first recovery period, such as reactions, negative side effects, and any laboratory test results needs to be forwarded. So first on our assessment list would be our ABCs: airway, breathing, and circulation. We're going to review each system when we take the patient from into the first recovery phase. All systems should be assessed for the patient. Pulse oximetry monitoring is a non-invasive way of measuring oxygenation. Oxygenation and ventilation can be affected by residual neuromuscular blockade. It can be affected by use of opioids and patient characteristics such as sleep disordered breathing from maybe obstructive sleep apnea, and also abnormal airway anatomy. So those are all important to note. Transcutaneous carbon dioxide and end-tidal carbon dioxide or capnography monitoring, again, is used to detect respiratory depression in high-risk patients. Volumetric capnography and acoustic respiratory rate monitoring have also demonstrated benefits in early identification of postoperative respiratory distress. ECG and blood pressures are always compared to baseline. Labs and diagnostics may be standardized for each institution, and with previous or various procedures may be also standardized. Continuing the assessment, we want to do a neurological assessment focusing on the level of consciousness, the patient's orientation, sensory and motor status, and again, the pupils. Hearing is the first sense to return, so be sure to explain all activities to your patient. For regional anesthesia, such as spinal and epidurals, sensory and motor blockade may still be present. A dermatome, excuse me, a dermatome level should be checked to determine the level of return from those blockades. Sensory and motor function return from the extremities to the site of injection. So when they feel like it's starting to wear off, again, it returns from the furthest from the injection site, moving back towards the injection site. Genitourinary assessment focuses on the urine output. A GI assessment includes bowel sounds, NG tube placement and drainage, and subjective reports of nausea from the patient. Remember that intake and output is also assessed to monitor fluid balance. Intake includes intraoperative fluids as reported by the anesthesia care provider. So be sure and check the IV. Output includes catheters, nasogastric tubes, and also wound drains. The surgical site is assessed for type and condition of drainage or dressing, and presence of drainage. So we're going to assess the type and condition of this dressing along with the presence of drainage. Pain and discomfort is assessed and treated promptly, and laboratory and diagnostic tests are carried out as ordered. Results are reviewed and reported to the primary care physician. We're going to discuss respiratory problems on this slide, students should look at table 19.5 on page 332. So airway obstruction is commonly caused by the patient's tongue and is most pronounced when supine and extremely sleepy. Proper positioning after anesthesia is important to maintain the airway. Other causes include laryngeal edema, which can be caused from an allergic drug reaction or mechanical irritation from intubation, and also fluid overload. Laryngeal spasm, which is irritation from the endotracheal tube or anesthetic gases, or gastric aspiration, most likely to occur after the removal of the endotracheal tube. And then there's retained thick secretions, and these secretions stimulation by anesthetic agents or dehydration of the secretions. Hypoxemia is a partial pressure of arterial oxygen less than 60 millimeters of mercury and is characterized by signs and symptoms including agitation to somnolence, hypertension to hypotension, and tachycardia to bradycardia. Pulse oximetry will be 92%, under 92%. Aspiration of gastric contents into the lungs may cause laryngeal spasms. It may cause infection and pulmonary edema. This is a potentially serious emergency. Atelectasis or alveolar collapse is the most common cause of hypoxemia. It is caused by retained secretions, decreased respiratory excursion, or general anesthesia, and occurs when mucus blocks bronchioles or when the amount of alveolar surfactant is reduced. You will see this on page 334 in figure 19.4. Atelectasis or alveolar collapse or pulmonary edema, which is fluid accumulation in the alveoli, can cause hypoxemia. Bronchial spasm is caused by increased bronchial smooth muscle tone, resulting in closure of the small airways. This results in wheezing, dyspnea, use of accessory muscles, hypoxemia, and tachycardia. Bronchial spasm may be seen more frequently in patients with asthma and chronic obstructive pulmonary disease, or COPD. Pulmonary edema is caused by accumulation of fluids in the alveoli and may be the result of fluid overload, heart failure, prolonged airway obstruction, sepsis, or aspiration. Pulmonary embolism is a thrombus that is dislodged from the peripheral venous system and lodged into the pulmonary arterial system. Hypoventilation is a decreased respiratory rate or effort and increase arterial carbon dioxide levels. This may occur as a result of depression of the central respiratory drive secondary to anesthesia and or use of opioids. This is atelectasis. If the patient has an airway obstruction, you may need to reposition the head or perform suctioning. Place the patient in a lateral recovery position until conscious. This position keeps the airway open and reduces the risk of aspiration if vomiting occurs. Reposition to supine once conscious to maximize expansion of the thorax. Once conscious, place the patient in a supine position with the head of the bed elevated. This position maximizes expansion of the thorax by decreasing the pressure of the abdominal contents on the diaphragm. Respiratory interventions on page 334 to 35. Apply oxygen via nasal cannula or face mask to keep oxygen sats at above 92%. Encourage the patient to take deep breaths. It helps keep the alveoli open, increases gas exchange, and promotes return to consciousness. Effective coughing and use of incentive spirometry prevents alveolar collapse and moves secretions to larger airways for easier expectoration. The incentive spirometer gives visual feedback of respiratory effort to the patient. Sustained maximal inspiration requires that the patient inhales as deeply as possible, and at the peak of the inspiration, they hold the breath for a few seconds and then exhale. This should be followed by a second deep breath and a cough. Reposition patients to promote full lung expansion and loosen and encourage phlegm to be expelled. Pain management supports the depth of breath the patient can take. Again, deeper breaths work to prevent atelectasis. Ensure that the patient is adequately hydrated, which helps thin thick secretions or prevents thick secretions, and it maintains integrity of the mucous membranes. Chest physical therapy mobilizes secretions. A patient may need to use a pillow or a rolled blanket for support when they are doing effective coughing if they have an abdominal incision from abdominal surgery. This helps to keep the incision from splitting open. This is called splitting. Or splinting, sorry. This is called splinting. The technique is shown in figure 19.7 on page 335 with correct positioning. Splinting provides support to the incision and aids in coughing and expectoration of secretions. Cardiovascular problems. The most common cardiovascular problems in the immediate post-anesthesia period include hypotension, hypertension, and dysrhythmias. Patients most at risk for cardiovascular complications are those with alterations of respiratory function, persons with a history of cardiovascular disease, older adults, and debilitated and critically ill individuals. Hypotension can cause hypoperfusion to vital organs, including the brain, heart, and kidneys. If this occurs, they will need oxygen and perhaps an IV fluid bolus, but check the surgical site to look for bleeding as well. Clinical signs may include disorientation, loss of consciousness, chest pain, and oliguria. The most common cause of hypotension in the PACU are unreplaced fluid and blood loss. Other causes of cardiac dysfunction are decreased systemic vascular resistance, dysrhythmias, drugs, and measurement errors, such as taking the blood pressure with an incorrect size cuff. Hypertension is most commonly the result of sympathetic nervous system stimulation caused by pain, anxiety, bladder distension, respiratory distress, hypothermia, or pre-existing hypertension. Dysrhythmias are caused by hypoxemia, hypercapnia, electrolyte and acid-base imbalances, circulatory inability, and pre-existing heart disease, as well as hypothermia, pain, surgical stress, and many anesthetics. Venous thromboembolism, or VTE, may form in the leg veins as a result of inactivity, body position, and pressure, which lead to venous stasis and decreased perfusion. Suspect a pulmonary embolism in any patient with tachypnea, chest pain, hypotension, agitation, tachycardia, and dyspnea, especially when the patient is already receiving oxygen therapy. Syncope or feigning is caused by decreased cardiac output fluid deficits or deficits in cerebral perfusion. It often occurs as a result of postural hypotension when the patient ambulates. So remember, when you are ambulating your patient, you want to get them up slowly from a lying position to a sitting to a standing position to avoid this. Cardiovascular problems and fluid and electrolyte problems. Fluid retention can result from the stress response and secretion of antidiuretic hormone and adrenocorticotropic hormone and activation of the renin-angiotensin-aldosterone system. This leads to significant sodium and fluid retention, increased water reabsorption, and decreased urine output, maintaining both blood volume and blood pressure. The stress response contributes to an increase in clotting tendencies by increasing platelet production. A venous thromboembolism, VTE, may form again in leg veins because of venous stasis, vein injury, or a hypercoagulable state. It is common in older adults, obese persons, immobilized patients, and patients with a history of PE or predisposition for clotting. It is a potentially life-threatening complication because it may lead to pulmonary embolism and infarction. Suspect pulmonary embolism again in any patient with tachypnea, chest pain, hypotension, agitation, tachycardia, and dyspnea, especially when they are already on oxygen therapy. Fluid overload can occur when IV fluids are infused too quickly, when chronic disease is cardiac or renal disease, or an fluid deficits can occur when untreated preoperative dehydration is present, blood loss during surgery, or slow or inadequate fluid replacement, vomiting, bleeding, and wound drainage, and can lead to decreases in cardiac output and tissue perfusion. Hypokalemia results from urinary and gastrointestinal tract losses and directly affect contractility of the heart, as well as result in decreased cardiac output and tissue perfusion. Patients who undergo GI surgery or receive diuretics may be likely to have electrolyte imbalances and may present as cardiac dysrhythmias or muscle cramps. Acid-base imbalances may be seen with patients who have irregular breathing patterns or respiratory depression associated with anesthesia. Cardiovascular interventions, vital sign monitoring, usually every 5 to 15 minutes in phase 1. This may be different depending on the facility, so always check the facility's policy. You want to compare your blood pressures and vital signs with preoperative and intraoperative results to determine if the vital signs are returning to baseline. Call the surgeon if any of these following occur: a systolic blood pressure less than 90 millimeters of mercury or greater than 160 millimeters of mercury, pulse rate less than 60 or greater than 120 beats per minute, pulse pressure, which is the difference between the systolic and the diastolic blood pressure. If the pulse pressure narrows, blood pressure trends gradually decrease or increase over several consecutive readings, changes in heart rhythm, and significant deviation from preoperative readings need to be reported to the physician. Hypotension with a normal and warm, dry skin is usually related to residual vasodilating effects of anesthesia and needs continued observation, possible medications. Hypotension with a rapid or weak pulse and cold, clammy skin, pale skin may indicate impending hypovolemic shock and requires immediate treatment. Treat hypotension with oxygen therapy to promote oxygenation of hypoperfused organs. Give IV fluid boluses to normalize blood pressure. Fluid loss and surgery. Inspect surgical incision for excess bleeding causing a volume loss. Assess for hypertension centers by removing the cause of the sympathetic nervous system stimulation, such as pain. Administer pain medications as prescribed to relieve that stimulation. You may need to administer blood pressure medications. A patient may have been NPO or may not have taken their daily regimen of medications that morning before surgery. ECG monitoring is recommended for patients with a history of heart disease and older adults who have undergone major surgery. Treatment is directed toward removing the cause or physiological alterations. Medication is a treatment for primary heart dysfunction. And advanced cardiac life support may be initiated for life-threatening dysrhythmias such as ventricular tachycardia. We want to continue to monitor vital signs, keep an accurate intake and output record, monitor laboratory findings such as electrolytes and hematocrit, and manage IV therapy after surgery. Early ambulation increases muscle tone, stimulates circulation, and prevents venous stasis and and VTE. VTE prophylaxis is recommended for patients with multiple risk factors for VTE, such as non-ambulatory or previous history of VTE. Low molecular weight heparin may be initiated, sequential compression devices, and slow position changes may prevent syncope or postural hypotension. So be sure and get up slowly, have them get up slowly. Patients are unconscious during surgery. Opioids are given for pain management, and neuromuscular blocking agents may be given to prevent patient movement on the operating room table. These medications need to be clear, and they need to clear the patient's system for return to baseline neurologic function and mobility status. Emergence delirium is a short-term neurologic change manifested by behaviors such as restlessness, agitation, disorientation, thrashing, and shouting, and may be a result of the type of anesthesia used, hypoxia, bladder distension, pain, residual neuromuscular blockade, or the presence of an endotracheal tube. This is more commonly seen in the older adult. Delayed emergence may result from prolonged action of opioids, sedatives, residual neuromuscular blockade, and inhalation agents. Patients may also experience anxiety from waking up in an unfamiliar location or be experiencing pain. Anxiety and depression may also occur with the loss of a body part from the surgical procedure. Postoperative cognitive dysfunction, including memory loss and inability to concentrate, may continue for weeks or months after surgery and is seen most commonly in older adults. Alcohol withdrawal delirium results from the alcohol withdrawal postoperatively. Clinical signs include restlessness, insomnia, nightmares, irritability, and auditory or visual hallucinations. Hypoxemia is a strong contributor to confusion and delirium. Continuous pulse oximetry and oxygen therapy should be applied. Maintain patient safety with the use of side rails, securing equipment such as IVs and artificial airways, and monitoring physiologic status, having the call bell available, and using 2 patient identifiers before giving drugs or completing treatments. Excessive pain may also contribute to confusion and disorientation. Provide pain medications is ordered. Complementary measures such as music therapy or acupuncture may support pain management. Pain may also lead to other complications. As before, it can lead to shallow respirations, increased risk for atelectasis. Pain may also delay the return of gastric and bowel function. Neuromuscular blocking agents will prevent voluntary muscle movement and contribute to anxiety and stress. Reversal agents can be given to reverse these effects. These should be administered in phase 1. Anxiety and depression may occur and correlate with increased likelihood for complications. These responses may be part of grieving for a lost body part or altered body function, or for loss of independence. Alcohol protocols may need to be initiated if withdrawal is suspected. Alcohol withdrawal may present as agitation, confusion, and irritability. Electrolyte imbalances should be corrected, as this can also manifest as confusion and irritation. Bowel and bladder function should be assessed. The need to pass the bowel or urinate without the ability to do so may contribute to irritation and agitation. Sleep-wake cycle may be disturbed, typically seen in phase 2 or extended observation areas. In the older adult, this may contribute to confusion. If the patient is confused, special attention must be placed on patient safety. Confusion will leave the patient at a higher risk for falls or at a higher risk for inadvertently removing or pulling invasive lines or injuring surgical areas. Physiologic factors include irritation of the skin and underlying tissues by incision and retraction during surgery. Reflex muscle spasms, positioning during surgery, and placement of various tubes may also contribute to pain and discomfort. Psychological factors include fear and anxiety. Other sources of discomfort include nausea and vomiting, environmental noises, noxious odors, and shivering. Patient-controlled analgesia, or PCA, allows this for the self-administration of predetermined doses of analgesia by the patient. The goals of the PCA are to provide immediate analgesia and to maintain an acceptable level of pain control. A plan for pain control that includes behavioral modalities and control of anxiety is developed pre-operatively. Patients are also taught to report pain and how it will be managed postoperatively. Single pain control modalities such as opioid drugs, patient-controlled analgesia, regional anesthetics or analgesics, and local anesthetics infiltration may be used postoperatively. Multimodal, multimodal analgesia, or the use of 2 or more analgesics given by various routes with different mechanisms of action, such as opioids and nonsteroidal anti-inflammatories or NSAIDs, is recommended when possible to achieve better pain relief with fewer or less severe side effects. IV opioids provide the most rapid relief from pain, whereas nonsteroidal anti-inflammatory drugs, or NSAIDs, decrease inflammation and pain. These can be given through a pain pump or IV push. Patient-controlled analgesia, PCA, involves self-administration, again, of predetermined doses of analgesia via an IV, through an epidural, orally, or transdermally route. Perineural local anesthesia, the infiltration of non-opioid medications into the surgical site. This is another method of managing postoperative pain. A disposable or mechanical infusion pump is used to deliver the local anesthetic via a catheter directly to the surgical incision site. Alterations in temperatures, Hypothermia is a core body temperature of less than 96.8 degrees Fahrenheit and occurs when heat loss occurs faster than heat production. Contributing factors are skin exposure during the surgical procedure and use of cold irrigants and skin preparations, as well as unwarmed inhaled gases. Shivering can increase resting energy expenditure and oxygen consumption. Carbon dioxide production contribute to increased heart rate, blood pressure, and intracranial pressure, as well as significantly affecting the patient's comfort level. Fever is often related to infection and may occur at any time during the postoperative period. Wound, respiratory, and urinary tract, and IV sites are all common areas of infection. Malignant hypothermia, MH, is a muscle metabolism disorder that is triggered by general anesthetic agents. Although often a late sign, it is characterized by a rapid rise in core body temperature and severe muscle rigidity. Other signs of malignant hypothermia include tachycardia, hypercarbia, metabolic and respiratory acidosis, myoglobinuria, and elevated creatinine kinase levels. Malignant hypothermia is a life-threatening complication. Most cases of malignant hypothermia occur during general anesthesia, but the first 1 hour period right after surgery, which is usually in the PACU, is a critical time. Malignant hypothermia causes a rapid rise in core body temperature to 105 degrees and higher and severe muscle contractions, as well as tachycardia, hypercarbia, metabolic and respiratory acidosis, myoglobinuria, and elevated creatinine kinase levels after receiving general anesthesia. Malignant hypothermia is a life-threatening complication that most often occurs again during general anesthesia, but may also be seen um, the first hour period immediately following surgery. Nursing management is to take the patient's temperature on arrival to the PACU and every hour if the patient stays normothermic. If the patient is hypothermic, take the temperature every 15 minutes until normothermic is reached. Use the same route of measuring temperature during the patient's stay in the PACU. Passive warming measures include warmed cotton blankets, warm socks, reflective blankets, and limiting skin exposure. Active warming can be achieved by the application of external warming devices, which includes forced air warmers, radiant warmers, and heated humidified oxygen and warmed IV fluids. Oxygen therapy is used to treat the increased oxygen demands caused by shivering. Opioids can be used to treat malignant hypothermia. Dantrium or dantrolene you will see as a common drug to treat malignant hypothermia. Meticulous asepsis should be used when caring for the surgical incision as well as the IV site. Coughing and deep breathing, as well as incentive spirometry, will help keep the patient's airway clear. Treatment for malignant hypothermia includes the administration of dantrolene with the onset of symptoms, in addition to measures to cool the patient, which will include ice packs, cold IV solutions. Acid-base imbalance should also be corrected uh, to reverse the signs of malignant hypothermia. Gastrointestinal problems, page 340. Postoperative nausea and vomiting is the most common complication affecting as many as 80% of high-risk patients and may lead to increased hospital length of stay and patient dissatisfaction. Most at risk are those that are less than 50 years of age, females, anesthesia and or opioids used during surgery, history of motion sickness or post-op nausea and vomiting, non-smoking status, and the duration and type of surgery will also affect the GI system. delayed gastric emptying, and slowed peristalsis that result from handling the bowel during abdominal surgery contribute to post-op nausea and vomiting, as does starting the oral intake too soon after surgery. Constipation may occur postoperatively due to anesthetics used during surgery that may paralyze the intestine, immobility, and alterations in diet and fluid intake pre and postoperatively, and the use of opioids for pain relief will all affect the risk for constipation. Risk factors for postoperative ileus include the use of opioids, immobility, older age, previous abdominal surgery, and early postoperative feeding. Use of opioid analgesia may prolong the duration of post-op ileus. Hiccups are intermittent spasms of the diaphragm that are caused by irritation of the phrenic nerve, which innervates the diaphragm. These may be caused by the presence of an NG tube or by drinking hot or cold fluids. Be sure to assess the presence of post-op nausea and vomiting. When ordered NPO, the patient may be kept hydrated with IV fluids. Begin oral intake when a gag reflex returns and patient can tolerate it. Position the patient in the lateral recovery position and have suction equipment available. Antiemetics will work to decrease feelings of nausea, whereas prokinetics will increase GI motility. Verify hydration status and blood pressure. An NG tube may need to be placed specifically with the GI surgeries until the return of bowel function. Complementary measures such as guided imagery may help support the nauseated patient. Assess for adequate hydration, specifically if the patient is vomiting. Assess for electrolyte loss with use of NG tubes and suctioning of GI content or vomiting of GI content. Be alert to risk for aspiration while patient is still sleepy from anesthesia. Assess for return of bowel function. And ways to do this is by chewing gum. It helps to mimic the act of eating and may stimulate gastric and bowel motility. Clear fluids may be ordered after the return of bowel sounds. Constipation may be prevented with the use of stool softeners and laxatives. Ambulation and frequent repositioning may provide relief also. Positioning the patient on the right side permits gas to rise along the transverse colon and aids its release. Increased mobility, although there is limited evidence regarding early ambulation and decreased abdominal distension, it is still a standard post-operative intervention. Urinary problems. Decreased urine output may be expected in the first 24 hours because of the increased aldosterone and ADH secretion resulting from the stress of the surgery. Fluid restriction before surgery and fluid loss surgery, drainage, and diaphoresis all will affect the decreased urine output. Urinary retention may occur related to the effects of anesthesia on the micturition reflex arc, or the ability to feel full, and the ability to initiate voiding. Retention is more likely to occur after lower abdominal or pelvic surgery because spasms or guarding of the abdominal and pelvic muscles interfere with the normal function of micturition. Oliguria, or diminished output of urine, renal ischemia, and altered cardiovascular status will also affect urine output. Oliguria can be a sign of renal failure and is less common, although more serious. Catheter-associated urinary tract infections are common in the hospital, and there is a risk, and therefore the catheter should be removed as soon as possible. By the second or third day, the patient will begin to have increasing urine output normally. Monitor urine output, have working knowledge of the type of procedure that the patient had, and if renal ischemia or cardiovascular compromise could have occurred. IV fluids is ordered, may be the result of fluid loss in the OR or GI losses. If the patient remains NPO, they will require hydration support. Monitor output with a Foley catheter if clinically indicated. If not, remove the Foley as soon as possible to prevent catheter-associated urinary tract infections and patient's ability to initiate voiding. If able, place the patient in a normal positioning for voiding. For males, this may mean standing and or sitting under commode versus the bedpan to pass urine, providing privacy, running water, offering water to the patient to drink, pouring warm water over the perineum. These all help with voiding. Walking and the use of bedside commode are other measures that will also help with voiding. If urine output is absent or low, non-invasive measures should be tried first. Performing a bladder scan to determine if the patient has urine retention is, if indicated, the patient may require being straight catheterized until the ability to initiate voiding returns. So this will save the chance of infection with by catheterizing someone who doesn't actually need to be if they're just holding urine in, and you can see that from a bladder scan. Integumentary problems, the surgical site infection, SSI. This continues to represent the most common health care acquired infection and accounts for 14 to 16% of hospital acquired infections. Surgical site infections are associated with prolonged hospitalizations, increased cost of care, and poor patient outcomes. The majority of surgical site infections are preventable with evidence-based strategies such as hand hygiene, selection, timing, and duration of prophylactic antibiotics, surgical site preparation, and maintaining perioperative normothermia. Evidence of surgical site infection usually does not become clear before the 3rd to 5th postoperative day. Local manifestations will include redness, swelling, and increased pain and tenderness at the site. Systemic manifestations will include fever and leukocytosis. Wound infection may result from contamination of the wound from 3 major sources, either exogenous flora from the environment, oral flora, or intestinal flora. Pressure may develop if drainage under the incision accumulates. The surgeon may place a drain in the incision or make a stab wound adjacent to the incision to allow for drainage. Dehiscence or separation of the previously approximated wound edges may occur with wound infection. Brown, pink, or clear drainage may precede wound dehiscence. Infection should be suspected and wound cultures obtained. Immediately after surgery, check the wound every 15 to 30 minutes or as ordered. When drainage appears on the dressing, record the type, the amount, the color, and the odor of the drainage. Assess the effect of position changes on the drainage. Does it increase or decrease and stop with a position change? The incision may be covered with a dressing right after surgery. Many healthcare providers prefer to change the first post-operative dressing themselves. If the initial operative dressing is saturated, follow your agency's policy as to whether you should change or simply reinforce the dressing. Assess the wound for signs and symptoms of infection. Wounds should go from sanguinous, which is a red color, to serosanguinous, a pink color, to serous, which is a clear yellow drainage. Note the type, color, amount, and odor of drainage if present. Note if there is any increase in drainage when moving the patient. It may indicate accumulation of drainage associated with an infection. General signs and symptoms of infection should be monitored for fever or warm red skin surrounding the incision. Administer antibiotics as ordered. There are protocols for types of antibiotics and duration of the antibiotic used for prophylaxis depending on the type of surgery. Maintain glycemic control. Hyperglycemia can contribute to the risk of wound infections. Discharging from the PACU, post anesthesia care unit, will be discharged from phase 1 to phase 2. This is on page 342 in your book. The choice of discharge is based on how well the patient is doing, their activity, access to follow-up care, and potential complications, the type of procedure or surgery that was done. This will vary depending on the facility and their guidelines. Often, standardized scoring is used as a guide, like the modified Aldrete scoring system. The modified Aldrete scoring system or other forms of post-anesthesia scoring systems may be used to determine patient readiness for transmission or transition from the phase 1 to the phase 2. This scoring system is a modification of the Apgar scoring systems for newborns, if you have heard of that yet. It has since been modified to more critically reevaluate the patient's oxygenation status. So when using the scoring system, it takes into consideration the patient's consciousness, their activity level, respirations, oxygenation, and circulation status. A score of 9 or 10 indicates readiness for transfer. Some institutions may accept a score of 8. Upon meeting specific criteria, patients are transferred from phase 1 to phase 2 care. This is an inpatient unit. The inpatient unit chosen should be appropriate for the patient's surgical procedure or condition to better meet postoperative needs. Before sending the patient to phase 2 care area, the patient should have a return of neurologic baseline, aware of the situation around them. They should be oriented. They should be able to follow commands, be hemodynamically stable. The blood pressure and heart rate are at baseline or close to baseline without any anticipated changes. The surgical site should have minimal drainage, and pain should be managed with a continued plan for further management. Even with all of that, it still may be difficult to determine just how ready the patient is to be discharged from phase 1 to phase 2 care. SBAR, table 19.9 on page 343, is a standardized communication tool that may be used to provide a complete report. SBAR stands for Situation, Background, Assessment, and Recommendation. The SBAR provides a complete report and enhances the safe transfer of the patient from the PACU to the clinical unit. Nurse-to-nurse communication is essential when the patient is moving from phase 1 to phase 2. Phase 2, page 343 and 344. Phase 2 care is in an inpatient setting. Nursing care focuses on preparing the patient for managing care at home or in an extended care environment, such as a rehab. Consider nursing care required during this time frame and equipment required to care for the patient adequately. Equipment would include the equipment that's required to care for the surgical procedure or condition of the patient. It may include surgical incision assessment and drainage change material, and it also may include braces or splints or ambulatory assistive devices if a joint was replaced, maybe in surgery. So this is the equipment typically required for post-surgical patients in a clinical unit. Some equipment, such as means to measure vital signs, are the same as you would have in the phase one. However, equipment required for intense monitoring would not be included in this phase. Added to the list is equipment such as bladder scanners, required to measure urine output and perform urinary straight catheterization if required. List of equipment required for specific surgery should be verbalized during the report from the PACU to the clinical unit so that the receiving unit is prepared to meet the patient's needs when the patient arrives. Extended observation. Patients may need to be transferred to an extended observation area, such as a rehab or rehabilitation facility, or remain on an inpatient unit for rehab. Nursing care continues to focus on preparing the patient for discharge of care. Equipment required will depend on the type of surgery, the patient population, and facility guidelines. Discharge criteria for ambulatory surgery. All PACU discharge criteria or phase one criteria must be met. No IV opioids must be given in the last 30 minutes. Voided if appropriate to the surgical procedure. The patient might be required to do something else, or another standard might have to be met, like passing air for a colonoscopy. Able to ambulate if not contraindicated. They cannot drive home. They have to have someone with them who can drive. They must have written discharge instructions. The nurse must go over these instructions with the patient and whoever brought them, unless the patient refuses to have that someone in during the instructions due to privacy. The patient must understand the instructions, such as having them repeat them back to you. Ambulatory surgery may also be referred to as same-day surgery. The patient comes to the OR, has the surgical procedure completed, and progresses to discharge readiness in the same day. Patients may have received general or regional anesthesia and be admitted directly to phase two care. Remember, this is called fast tracking. Fast tracking accounts for about 70% of surgeries performed in North America. The patient leaving the ambulatory surgical setting must be near preoperative levels of functioning. A responsible adult, again, must be present to transport the patient from the PACU. Postoperative teaching is provided to the patient and the caregiver and reinforced with written instructions. A post-anesthesia scoring system, similar to the modified Aldrich scoring system, may be used to determine discharge readiness. Preparations for the patient's discharge is an ongoing process that begins before surgery. These instructions and discharge planning is provided to the patient and caregiver specific to their surgery and anesthesia. It includes incision care and dressings. It includes medication education, especially pain medications. Activities that are allowed and prohibited will be covered, and dietary restrictions and what is allowed. Discharge education is of the utmost importance. Patients and their caregivers are expected to continue self-care of the incision, the tubes, the drainage systems at home. In collaboration with the case manager, patients are patient care navigators, discharge planners, the nurse helps to facilitate a safe transfer home. Consideration for access to a pharmacy, a phone in case of an emergency, and access to follow-up care must occur before this discharge. Common reasons to seek help after discharge for patients is unrelieved pain, questions about medications, wound drainage and or bleeding, increased drainage from a drainage device, and fever greater than 100 degrees Fahrenheit. Phase 2 discharge criteria. From phase 1, just a second, please. Okay, from phase 2, patients may be discharged home or to an extended observation unit. Hemodynamic stability or return to baseline blood pressure and heart rate must be at baseline or near baseline. Baseline mentation of neurological status. Adequate urine output must also be present. Pain must be managed, and the patient reports the pain is tolerable. Surgical site dressing is without excessive drainage. Tubes and drains are draining as expected, the expected color and consistency of the drainage, and it has the expected amounts. So anything unusual would not be a criteria met for discharge. Fluid and hydration, the patient may be taking PO fluids, or if in PO, the patient is receiving IV fluids. A Foley may be in place, or the patient may be actually voiding. No symptoms of dehydration, such as increased heart rate or hypotension, and no symptoms of fluid overload, such as rales and generalized edema are present. The patient's mobility status is assessed and monitored dependent on the type of surgery. Early mobilization can prevent numerous complications and is an early goal. The patient may be receiving narcotics that may affect the mobility status. Patient safety is a priority during this time to prevent falls and other injuries. Patient safety needs may be positioning in the bed, fall precautions, and use of assistive devices. Interactions are important with significant others, as they may be caregivers upon discharge. Discharge teaching should include education for the patient and their caregivers. Discharge criteria may vary based on the type of surgery performed. Care during phase 2 focuses on educating the patient to assess and potentially manage tubes and drains or other care associated with the surgical incision or procedure. For the elderly patient, we have some special considerations that we have to take into account while caring for them and in preparing for discharge. The older adult has decreased respiratory function, including decreased ability to cough and decreased thoracic compliance, which may lead to an increase in the work of breathing and a decreased ability to eliminate drugs. Altered vascular function as a result of atherosclerosis and decreased elasticity of blood vessels, along with the possibility of decreased circulating volume and hypertension, may all lead to cardiovascular problems. Renal function in the older adult normally decreases, causing a reduced ability to remove drugs and increasing the risk of drug toxicity. Decreased liver function also leads to reduced drug metabolism and increased drug toxicity and activity. Age, history of alcohol abuse, and poor baseline cognition, hypoxia, severe metabolic imbalances, and hypotension may contribute to post-operative delirium in older adults. Older adults may hesitate to ask for pain medications. They may have impaired communication or may have physiologic changes that affect how drugs are metabolized. So very careful when assessing our elderly population and deciding on discharge and discharge criteria.